Hello, everybody. Welcome back. We continue our discussion on management of diabetes in pregnancy, a clinical update. Today's topic is long-term consequence of GDM to the child. What are the consequences of GDM to the child? GDM also poses short and long-term consequences for the infant. The increase in placental transport of glucose, amino acids, and fatty acids stimulate the fetus's endogenous production of insulin and insulin-like growth factor 1 or IGF-1. Together, this can cause fetal overgrowth, often resulting in macrosomia at birth. Excess fetal insulin production can stress developing pancreatic beta cells, contributing to beta cell dysfunction and insulin resistance even prenatally. Macrosomia is also a risk factor for shoulder dystocia, a form of obstructed labor. Thus, babies of GDM pregnancies are usually delivered by cesarean section. Once delivered, these babies are at an increased risk of hypoglycemia, which is likely due to formed dependence on maternal hyperglycemia, also called fetal hyperinsulinemia, which can contribute to brain injury if not properly managed. There is also evidence that GDM increases the risk of stillbirth. In the long term, babies that are born of GDM pregnancies are at increased risk of obesity, type 2 diabetes mellitus, cardiovascular disease, and associated metabolic disease. Children born of mothers with GDM have almost double the risk of developing childhood obesity where compared to non-diabetic mothers, even after adjusting for confounding factors such as maternal BMI, body mass index, and impaired glucose tolerance can be detected as young as 5 years old. Females are therefore more likely to experience GDM in their own pregnancies, contributing to a vicious intergenerational cycle of GDM. What about the long-term health of the child? Several but not all studies of growth and development of offspring of mothers with diabetes mellitus indicate an increased risk of obesity during childhood and adolescence. Some of this effect could represent simple heredity or shared environment between mothers and children. However, several observations suggest an independent effect of exposure in diabetes mellitus in utero. First, offspring of mothers with diabetes mellitus have a higher risk of developing obesity than the offspring of fathers with diabetes mellitus. Second, offspring of mothers with type 1 diabetes mellitus, who are generally not obese, have higher body mass index by age 14 to 17 years and more often have impaired glucose tolerance than offspring of non-diabetic mothers. Third, and most convincingly, in sibling pairs discordant for exposure to maternal diabetes mellitus, offspring born after the mother developed diabetes mellitus have a higher body mass index and higher risk of developing diabetes mellitus than offspring born before the mother developed diabetes mellitus. In Pima Indians, glucose level in the range diagnostic for GDM were associated with an increased risk of obesity in offsprings. This finding suggests that fetal exposure to maternal diabetes mellitus, including GDM, influences important aspects of regulation of appetite and or energy expenditure in favor of positive caloric balance. Interestingly, the effect of maternal diabetes mellitus on offspring does not become manifest as increased body mass index until after 2 years of age, and effects on other components of the metabolic syndrome, including hyperglycemia, have been observed. All of these findings suggest that exposure to maternal diabetes mellitus in utero could be an important contribution to the rising rates of obesity and diabetes mellitus that are occurring in developed countries throughout the world. Now, how do we improve the long-term health of the child? Little high-quality evidence exists to help guide clinicians to reduce the risk of obesity and diabetes mellitus in the offspring of mothers with diabetes mellitus. Breastfeeding has been associated with reduced long-term risk of obesity and diabetes mellitus compared with bottle feeding in several observational studies, some of which included mothers with diabetes mellitus. The hope that aggressive control of maternal glucose levels in pregnancy might also mitigate the development of obesity in their children remains to be realized. Follow-up of the ACH-OIS study, in which diagnosis and treatment of GDM led to reduction in birth weights and macrosomia rates in the offspring, did not reveal any intergroup differences in the body mass index z-scores of offspring by age 4 to 5 years. The metformin in gestational diabetes trial compared metformin with insulin in women with GDM who require intensification of treatment beyond dietary therapy. The two treatments provide similar perinatal outcomes, including birth weights and skin fold measurements in the newborn. At age 2 years, offspring of the two treatment groups had similar body adipose tissue content, but the offspring to the metformin group had small, 3 to 6%, but statistically significant increases in skin fold thicknesses. The author suggested that this might reflect the increased subcutaneous and reduced visceral adipose tissue in the metformin group, but that suggestions remain to be proven. Thus, other than breastfeeding, currently no interventions have been proven to reduce obesity and its complications in offsprings exposed in utero to GDM or any other form of diabetes mellitus. However, excess rates of obesity in offspring from mothers with GDM may take years to develop. Therefore, long-term studies will be required to provide definitive information on this issue. This ends our discussion on long-term consequences of GDM to the child. See you next time when we discuss preconception care and counseling.